Hello friends, in this video I'll be showing a surgical demonstration of IPCL surgery. I do my surgery from the superior sitting position most of the times. When we are doing it in superior position, these optic eyelets have to be placed superior, as well as this leading flange also has to be superior. So in this animation I'll just show you how it is done. We make the main port at 150 degrees and two side ports which are diagonally opposite to each other. The lens is then injected through the main wound, and you can see it has to be in correct orientation. These optic eyelets have to be superior as well as the leading flange has to be superior. Once it is in this position, the IPCL will be properly oriented, tented upwards. And now with a dialer, it can be dialed to 180 degrees. So it's quite convenient for doing it superiorly. The orientation has to be same for the right and left eye. It doesn't have to change. So in the surgery, I'm making the main wound with a 2.8 millimeter keratome. I like to do my entry in a very controlled manner so as to not cause any damage and a slight increase in the wound. I fill the chamber with viscoelastic. HPMC is the viscoelastic of choice in these cases. And two side ports. The right side port is made about 60 degrees away from the main wound and the left is around 120 degrees away. This ergonomically works best for me. Now, in the IPCL cartridge, you can see it's a butterfly type cartridge. I'm injecting viscoelastic, again HPMC, and putting the lens now in the correct orientation. How do we know it's correctly oriented? You can see here that the two optic eyelets are placed superiorly and the leading flange is also superior. Now, I put one edge inside and just press the center and then put the second edge into the cartridge. And when this is done, we know that it is bent downwards. It should not be bent upwards like the ICL. And then the cartridge is closed. Now I put it into the injector and just push it slightly and then release backwards just to make sure that it's not entangled in any way. And once I'm sure that the lens is free, I slowly inject it. Now injection has to be done in a very slow and controlled manner. With my left hand, I'm using an aspiration cannula just for support. And the wrist has to be turned in clockwise or anti-clockwise direction to make sure the orientation is correct. Now you can see the leading flange is superior as well as the superior optic eyelet, so I know it is entering in the correct orientation. And once it is done, I inject some amount of OVD above the lens to separate it from the cornea. And now dialing it into the 180 degree position. Now I use the right side port to engage the opposite flanges. So there are three flanges. One at the side is put in, the central one, and the other one at the side can be just nudged in by a slight side to side movement. The left side port is used for the opposite flanges. Again, doing the first flange, pushing it gently, and then the central one, and finally the third flange. If it doesn't go, just a small nudging can be done, and now the lens is well centered. Now I use irrigation cannula from the main wound to just remove all the viscoelastic. At this point, I'm not aspirating anything, I'm just irrigating the wound and slightly depressing it so that the OVD comes out. And then I put in the irrigation aspiration from the side ports and gently aspirate. The aspiration is done near the central hole so as to remove the OVD from behind the lens and just nudging it slightly backwards. All the OVD is out and the surgery is completed with hydration of the side ports. You can see while removing the speculum, the lens is well centered. This is post-op day 1. We can see a well-centered IPCL with the central eyelet. Pupil is free. This is slit illumination showing a good vault and the IPCL in situ.